So first of all, I want to thank again Professor Sharif who invited me here, and all the faculty for the friendship, which has been fantastic, and I could share their friendship and exchanging ideas about everything, not just about neurosurgery. So I have to talk about emergency evaluation management of the hydrocephalus and shunting. Everybody knows everything about the ventricular system and the production of CSF. You have these four ventricles and the choroid plexus producing CSF. Circulation is going through the ventricles and in the subarachnoid space. And of course, the circulation should be perfect in order to maintain the regular content of CSF in the skull. The production of the CSF is not just by the intracranial choroid plexus, but it's also by ependymal lining, interstitial space, spinal dura of the nerve root sleeves. What is strange is that in some way water is making a communication, water which means CSF, is making a communication in between arterial vessel and venous vessels. So it's some magic system which makes water communicate from the two compartments. The reabsorption will be through the dura venous sinus, nerve root sleeves, and that transependymal also parenchymal capillaries. It is surprising when you look at the content of the CSF to see that the ventricular content, which is third ventricle and fourth ventricle, are just a minimal portion, just about 6 to 7 cc. On the contrary, plus the 30 millimeters of the lateral ventricle. So, but the ventricular system, it's accounting for less than 25% of the entire CSF content of the cranial and spinal container. The function of the CSF are protection, neuroendocrinal, pH, metabolic, thermal, and protecting against ischemia, intracranial pressure, and perfusion, and also flushing metabolic toxins. Everybody knows the Monro-Kellie doctrine, which is fundamental because the cranial compartment is incompressible, and the volume inside the cranium is a fixed volume. So the blood and CSF are accounting for only about 8% of this content, and any increase in the content of the skull will rise intracranial pressure, and the compliance of the system in some ways very low, because after you reach 25 millimeters of mercury, the system will fail. Hydrocephalus, easy to know, it's water in the skull or in the brain. And the most common cause, this is also a bit surprising, it's are not for sure mass or tumors, but are intraventricular hemorrhage or subarachnoid hemorrhage, malformation, and tumor account only for about 13%. A very common cause, which can be taken apart from the other malformation, is aqueductal stenosis. So if you're facing an acute hydrocephalus in your emergency room, this scheme should be always kept in mind. Hemorrhage will account for a lot of this hydrocephalic condition. This is something that has been found, which is the first possible treatment of the hydrocephalus, which has been done by this Arab author, a Syrian one, around the 10th century. Then there is a report in the 18th century by a French guy, Claude Nicolas, but the first attempt to shunt outside the ventricle, the CSF, was done in 1744 by this Claude Nicolas Lecat. It was, as a matter of fact, an external drainage exactly as we could do now. The patient died after 5 days, was a kid. Then we moved to the modern times, and The first real drainage was the one in 1939 by Arne Torkildsen. As a matter of fact, he was shunting from the ventricle to the cisterna magna. It was a first sort of ventriculostomy. When I was young, I made a lot of revision surgery of this Torkildsen system, which were functioning fairly well for many, many years, mostly in kids. Then we move to the era of the ventricular shunting by the use of valve or by the use of catheter. So the first ventricular atrial shunt was done by these four authors in 1949, and during the same year there was the first ventricular lateral shunt. Is just historical, but the modern ventricular peritoneal shunt has started very lately, in 1954. In 1960, ventricular pleural shunt. So it was Penfield who first described this ventricular peritoneal shunt. Hydrocephalus can be distinguished in between non-obstructive and obstructive, communicating, non-communicating. Of course, you will have in non-obstructive all the fourth ventricle dilating, and also in the communicating. If it's not communicating, you will see in most of the case some obstruction of the aqueduct or basal foramina. Malformative hydrocephalus, it's accounting for a lot of cases, carry 1, carry 2, primary aqueductal stenosis, Dandy Walker, hydranencephalia, or is post-infection, post-hemorrhagic, post-traumatic, secondary to mass lesion. CT scan, it's enough to detect ventricular dilatation. Maybe it's not enough to detect a tumor or AVM affirmation, but it's enough to define the size of the ventricle and the eventual presence of blood. In this case, you have blood in the ventricle or in some subarachnoid space, or in this other case with infection, ventricular infection. Of course, you will not be allowed to make a shunt, external shunt. What you should be done should be external drainage. Of course, if you're facing a tumor, you have to take into consideration, as we'll see later, two possible type of procedure. One is shunting, the other one is ventriculostomy, because in some cases it could be enough to solve the problem. Of course, you need to have the posterior fossa compartment, which means fourth ventricle and subarachnoid system, which is functioning, otherwise it will not work. So even in emergency surgery now, we take into account also the chance to perform ventriculostomy. The type of shunting we can consider are the most common: ventricular peritoneal, ventricular atrial, ventricular pleural, quite uncommon, and lumbar-peritoneal. I don't like the last one because in my experience it will fail in most of the cases. We have seen the borehole exercise. So first thing is to teach to a neurosurgeon how to make a frontal borehole and make a ventricular drainage. And also you can perform, of course, a drainage by occipital approach or parietal approach. This was a device which has been invented many years ago to give you the proper angle when you're, everybody knows this magic number, 13 centimeters, 3 centimeters, to get the borehole and the coronary fissure. And this device is helping you to go medially in the proper way. Now, if we move talking about the system we're using, we can use a normal catheter, but catheter which have antibiotic impregnation. First type of hydrocephalus that has been invented, of shunting which has been invented, ventricular atrial. It's quite easy to perform. You need to have some tricks. And now, in many cases, we do it by the aid also of anesthesiologists who are quite accustomed to get all these veins in subclavian space. Ventriculopleural, I do not know exactly how to do it. I just scholastic, what I'm showing now. Of course, the length of the catheter is something which can be predicted. About 5 centimeters. The ventricular catheter should be just about 5 centimeters in the frontal region, 10 centimeters if you go by the occipital region. The length of the catheter, mostly if you're dealing with young patients, of the peritoneal catheter should exceed at least 12 centimeters in order to prevent the failure of the system by the growth of the child. If we're talking about a type of valve, it's a sort of mess because there are now 190 type of valve in the market. And now this is something missing here. There was okay. These are the valve which have been progressively developed. And I think that this one, the Akim, it's a sort of milestone in this field of valve. There are gravitational valve, this valve which is not affected by magnetic field. But mostly we are now utilizing, and I can show it clearly, these three type of valve. And mostly this Hakim, which is programmable valve. You can have 18 different adjustments of the pressure. Now a new type even came out, which is easier to adjust and which will not be affected by magnetic field. Normal pressure is between 7 and 15 millimeters. If you are in a chronic condition of hydrocephalus, maybe you can profit for defining the pressure by continuous monitoring of CSF, because instant evaluation of the pressure is not reliable. But mostly you will use low 4, 8, 12 millimeter of mercury, the three type of pressure you will choose for the patient. This is another type of valve, the anti-siphon, but we have been using it. We have been deceived in many cases because the scar which will surround the valve in many cases will prevent this pressure-related mechanism to function. Of course, as any other procedure, also shunting has a lot of possible complication. Most common, of course, subdural hygroma or malpositioning, which is can be done from the beginning or can be consequent to the reduction of the size of the ventricle. Also, if you have this valve which are adjustable, you have to keep in mind that magnetic field can really damage the functioning of the valve. You can have also local complications, shunt migration, tube infections, tube obstruction, or knot disconnection fracture. I'm not going to talk about non-pressure hydrocephalus. As a whole, if you're talking about emergency shunting or emergency dealing with hydrocephalus, I would just say keep in mind that you can perform with endoscopic ventriculostomy, which would be better in many cases for the patient, aqueductal stenosis, for instance, and nor use a valve possibly which can be adjusted later on, because in many cases the proper I forgot to mention also slit ventricle, but the proper pressure of drainage sometimes very difficult to be established. So I just want to thank you again, and I want to invite you to Milan in next June for our biannual meeting of the Spinal Committee. Thank you very much.